Hello everyone. I've been tasked to talk about upper GI endoscopy for suspected cancer. Today, I'm going to give you an update on high quality upper GI endoscopy, standardized terminology, and biopsy protocol. I will then talk about the three most common early cancer lesions in upper GI, namely early squamous cell carcinoma, dysplastic Barrett's esophagus, and early gastric cancer. Finally, I will give you an update on how to discharge patients from two-week pathway post-gastroscopy. Types of upper GI cancers include esophageal, gastric, duodenal, pancreatic, gallbladder, biliary, and hepatic cancers. And together, they account for over 10% of cancers in the UK. The three first type of cancers, esophageal, gastric, and duodenal, are the ones that can be diagnosed with upper GI endoscopy, and this is the focus of our talk today. Just a bit of background here. Overall, 11% of missed cancers in upper GI diagnosed following a negative gastroscopy. And nearly 24% of all cases of esophageal adenocarcinomas occur in patients with baseline non-dysplastic Barrett's esophagus diagnosed within 1 year of a negative OGD. And clearly that indicates suboptimal upper GI endoscopy performances. And how to improve our performance. The general advice for improving lesion detection are spending longer time during gastroscopy. So at least 7 minutes should be spent in looking at different areas of the upper GI. Adequate mucosal visualization. This definitely should be part of our regular practices. Fluid aspiration, insufflation, use of mucosal cleansing agents. We all should use high definition white light endoscopy in this day and age, and with or without image enhancement. Use of standardized terminology, especially if the patient needs to be referred, is very important. And awareness of the updated biopsy protocol if any pathology is suspected. And of course, photo documentation. So as bare minimum, we should have photo documentation from mid-esophagus, lower esophagus, GOJ region, retroflexion at the cardia and fundus, with photo documentation of this region, mid-gastric body, incisura, antrum, D1 and D2 photo documentation is required. Briefly talking about standardized terminology here. So the common classifications we should all be aware of are LA classification for GORD, Prague classification for Barrett's, updated Sydney classification for chronic gastritis, Paris classification for global lesion description or tumors, Forest classification for peptic ulcer bleeding, Sorin classification for gastric varices, or Seward classification for GOJ cancers, or modified Paquet classification for esophageal varices. There are more specific classifications for specific lesions, like if you do FAP surveillances, awareness of Spiegelman classification, for early gastric cancer lesions, VS classification, or for early squamous cell carcinoma, IPCL or Inouye classification are useful. EREFS classification for eosinophilic esophagitis, I find it quite useful as well. Moving on to biopsy protocols. For suspected eosinophilic esophagitis, at least 6 biopsies are required, usually 2 from the distal and 4 from mid and proximal esophagus. Regarding Barrett's esophagus, 4 quadrant biopsies every 1 to 2 centimeters of the Barrett's esophagus, namely Seattle protocol, along with targeted biopsy of any mucosal abnormality. For dyspepsia or suspected H. pylori on patients using PPI, 5 biopsies from antrum and gastric bodies according to AGA guidelines in 2 separate parts. So 3 biopsies from the antrum and incisura in 1 part, and the second part from the body, 1 from the lesser cave and 1 from the greater cave. And essentially this is the updated Sydney protocol biopsies, which also is useful when you have high-risk stomach, when there's suspicion of gastric intestinal metaplasia or atrophic gastropathy. So updated Sydney protocol biopsies are required. For gastric ulcers or duodenal ulcers, urease test is necessary, or if patients are on PPI, gastric biopsies. For peptic ulcers, if gastric ulcers are biopsied on or during index endoscopy, then biopsy specimens should be taken from basin edges of the ulcers. In terms of gastric polyps, the description of solitary or multiple polyps are important, whether in terms of endoscopic assessment, they're highly in favor of fundic gland polyps, hyperplastic or dysplastic. If there are suspicion of any dysplasia or in fact hyperplastic polyps, they should be biopsied. If there are numerous, then representative biopsies of the larger polyps are adequate, but any dysplastic polyps should be biopsied with clear description of the location and Paris classification. For celiac disease, 4 biopsies from D2 and plus minus 1 to 2 biopsies from the duodenal bulb. For esophageal ulcers, severe esophagitis, grade C and D, or atypical appearance within the esophagus, biopsies either are required during index endoscopy or if severe esophagitis is required and there's diagnostic uncertainty, to rescope following high-dose PPI in 6 weeks' time. A stricture biopsy is necessary prior to any endoscopic intervention. For iron deficiency anemia, duodenal biopsies or D2 biopsies are necessary, especially if celiac serology is positive or not tested. According to BSG guideline, modified Sydney protocol biopsies are also required, but this is not advised by the latest AGA guideline. For any malignant looking lesion, minimum of 6 biopsies or 8 biopsies are required. So 6 to 8 is standard number of biopsies required for malignant looking lesions. Very quickly, I'm going to talk about how to remove patients from the two-week pathway post-endoscopy. I'm sure all colleagues are aware of these practices, and this is just a reminder for everyone. So a suspected cancer pathway can only be ended if cancer is excluded or at the point first definitive treatment is given. So pathways cannot be closed if patient doesn't attend appointments or diagnostics unless a clinical decision is made and there have been at least 2 DNAs of fully agreed appointments. And every effort should be made to establish the reason for the DNAs. Pathways cannot be closed if cancer is unlikely but has not been excluded. And national rules dictate that all non-cancer diagnosis must be conveyed to the patient, and it should be clearly documented. We cannot remove a patient from two-week pathway unless we inform the patient during endoscopy. Normally, most patients are informed in clinic during a telephone consultation or following negative diagnostic. But if pathway is ending via endoscopy, this must be documented in endoscopy system, as well as the patient should be informed at the same time. This is just a flow chart of what we've just discussed for removing patient from two-week pathway for everyone's perusal. Many thanks for your attention.
Welcome to this GM Cancer webinar. My name is Dr. Roger Prudham. I co-chair the Greater Manchester Colorectal Cancer Pathway Board, along with Mr. Selvaseca, and I'm Clinical Director for the Pennine NHS Bowel Cancer Screening Programme, a post I've held since the beginning of the screening programme in 2007-2008. What I'd like to talk to you all today about is how we can enhance the delivery of cancer diagnostics in endoscopy. I'm going to speak particularly about lower GI, and of course, Aras is speaking about upper GI. The contents of the talk are, I'll talk about the context first of all, why we're doing this, and then I'll explain how we can clearly recognize advanced colorectal cancer and how we can determine what is a polyp cancer, and then crucially, the communication standards we should employ in respect of how we record information in systems, and more importantly, what we explain to patients. So the context is that lower GI cancer is the second or third cause of cancer death in our community and across most of the world. It can affect up to 1 in 19 of us on current statistics. And so the colorectal cancer pathway is a very high volume pathway for all providers. So all providers have the task of managing patients on these pathways and making sure that patients are informed correctly when a diagnosis is made, and also informed correctly and assured when a diagnosis is excluded. This is performance managed by NHS England for all providers via the 28-day faster diagnostic standard, and we all report into GM Cancer and into NHS England on our performance there. Colorectal cancer forms a large part of that pathway, and that's important in respect of the timeliness of cancer investigations and progress through a pathway when cancer is diagnosed. Here is a picture of a typical colon cancer endoscopy. It is usually pretty obvious when we see it. We're all familiar with it. We'll all recognize that that is a cancer. And what I'll talk about now is how we know that. If we look at this image and we think about how cancers look at endoscopy, many of them are ulcerated, not all of them, but ulceration within a lesion that has a thick rolled edge standing proud from the mucosa is a clear indication that there is a cancer evident. It is usually tethered, so the cancer is pulling in the mucosa that's adjacent to this lesion, and we can see puckering of adjacent mucosa when we look carefully around the edges of the polyp stop. It's highly vascular, and we can see there is lots of pit pattern here, and often these lesions will bleed on contact, and in the colon that we scope leading up to where these lesions are present, we'll see flecks of blood or sometimes altered blood, and we may anticipate that a cancer is about to appear. So all this is very typical of a colon cancer that we see at endoscopy. And how we should manage that is that we should take a minimum of 10 biopsies. We should aim for the margins of the lesion rather than the necrotic tissue that's going to be in the center, which won't be diagnostic. We should tattoo the lesion to facilitate the laparoscopic localization of the lesion, unless it's in the cecum or the rectum, where that's not necessary. And in tattooing, we should be careful that we raise saline bleb, so we tattoo the mucosa and we reduce the chance of transmural contamination with ink, which can make laparoscopic resection more difficult. And of course, we should inform the patient that we've identified a cancer and of what the next steps are in respect of referral to MDT and staging, and wherever possible, we should seek to get a same-day CT tap. That's a CT of the thorax, abdomen, and pelvis. It's not always possible, depending on the time of day and depending on the provider and depending on what the radiology department have got to deal with in that day. But I would advise that we always ask the question, and my experience is that whenever possible, radiology departments will facilitate that when a cancer has been diagnosed. And of course, the colon is ideally prepared to undertake a staging CT at the time of a completion of a colonoscopy. The next thing I want to discuss is how we identify polyp cancers. How is it that when we look at a polyp, we can be confident that it is not yet a cancer, or in cases where we do see a polypoid cancer, how do we know that there is a cancer present? Well, to do that, we blend together three things, really: the morphology, the pit pattern, the vascularity. And there are objective criteria for determining how we describe each of these. Paris for morphology, Cudo for pit pattern, and NICE for vascularity, and I'll go through each of them in turn. So here's the Paris classification, very simple scheme. We'll all be familiar with this, and it is built into all endoscopy software, reporting software these days, but just to, for revision, 1P, clearly pedunculated, sitting on a stalk there, 1S, sessile, and in continuity with the mucosa, a 2A, sitting flat but slightly proud of the mucosa, 2B, sitting right in line with the mucosa, and 2C, depressed, and 3 clearly ulcerated through the submucosa. And we can have combinations of all of them, given that polyps don't like to always just sit neatly into one category. In respect to the 2As, we can subdivide those into the laterally spreading tumours, which are granular or non-granular, and as I'm sure you're all aware, the smoother and flatter that an LST polyp looks, the more likely it is to harbour a cancer. We combine that together with it looking depressed, then we can see that we're much likely to have a cancer which is tethering the underlying submucosa. Whereas if it sits proud of the mucosa and has a granular villus-looking pattern, then it's much more likely to be benign in nature and resectable. Classification that is built into endoscopy reporting systems, and you'll all be very familiar with it. It's worthwhile just revising it so we can underline how you can use this to be really confident in describing the pathology of the polyps that are being identified. So normal mucosa has this typical round pits, uniformly distributed throughout the mucosa. Type 2 pit pattern is more typical of an SSL or hypoplastic polyp, where these pits are expanded and take on this star-like morphology. With adenomatous polyps, we will again have small rounded pits, but these are crowded and smaller than the surrounding mucosa. And conveniently, of course, there will always be some surrounding mucosa to compare against with an obvious demarcation. So that's how you can distinguish between the adenomatous small rounded pits and the physiological larger rounded pits of normal mucosa. As these pits, as a polyp matures, these pits elongate into more tubular structures. We see this very nicely demonstrated here. This is a 3L pit pattern. And again, as a polyp grows even further, these pits expand further, they start to branch out, and we get this more gyriform pattern typical of type 4, which we'd see in a tubulovillous adenoma, of course. And then as a polyp progresses and there are more gene deletions, more unregulated cell growth, then the pattern breaks down and we have this loss of pit pattern in the surface of a polyp, often with increased vascularity too, of course. So the next slide shows the nice classification, International Colorectal Endoscopic Classification for vascular pattern. And this is subdivided to 3 types, and very, very useful if using narrowband imaging or enhanced imaging to take away the red end of the spectrum to reveal blood vessels. So here we see type 1. This is lighter than the background mucosa in color. There are either no or 1 or 2 isolated lacy vessels coursing across the lesion. You can see this star-like pit pattern in magnification here at the bottom. So this is all very typical of a hyperplastic polyp with a type 1 vascular pattern. In a type 2 vascular pattern, there are lots more blood vessels around. These are regularly organized around these white structures here, and maybe oval, tubular or branched. And typically, this is darker than the surrounding mucosa. You can see this is much browner than the adjacent mucosa here. And in type 3, the pattern is broken down completely, but there is intense vascularity, but those vessels are disrupted, maybe missing, maybe larger, and this is typical of a cancer. To revise things over here, here is a type 1 hyperplastic polyp. It's paler than the surrounding mucosa. It's relatively hypovascular, and you don't see those glandular structures, so we haven't got those crypts surrounded by regular dark blood vessels as we see in the adenoma in a moment. Here's a typical adenoma, a mesh of capillary vessels surrounding glands which are pale. So these red-brown structures here are blood vessels, well developed, and that's darker than the surrounding mucosa you can see here in this MBI image. And here's a cancer. There's a lack of uniformity, crowded irregular vessels with an amorphous surface pattern. Size is important too, of course, we all know that. Here is some data illustrating that as polyps get bigger, the chance of them becoming a cancer is much greater. And those of you who've done the optical diagnosis training with the bowel cancer screening program will know that for polyps less than 5 millimeters in size or diminutive polyps, there is almost no chance that there will be a cancer evident. There are a number of large published series which show that the percentage of polyp cancers is pretty much 0 at less than 5 millimeters in size. However, as polyps enlarge, the chance of cancer being evident increases. It's still very small for these diminutive polyps, less than 10 millimeters in size. So if we combine size with the morphology and the vascularity and the pit pattern, then we should be very confident in diagnosing or excluding cancer in polyps, and keeping a patient on a PTL awaiting histology should be the exception and certainly not the rule. So as a guide, step down where there is no cancer, where there are no polyps greater than 10 millimeters in size, or where polyps between 10 and 20 millimeters in size have no evident type 5 pit pattern. They are nice 1-2 on narrowband, and there's no evidence of Paris 2C in flat lesions. For 1P polyps, if there's a clear resection margin, no type 5 pit pattern, the Cudo and nice, if you've got a lack of type 5 on Cudo, sorry, and nice 2, then there is no cancer and step down. Do not step down, of course, where there is a clear cancer or where there is Paris 2C. And in general, with polyps greater than 30 millimeters, I think it is sensible to maintain patients on the PTL. If there's type 5 pit pattern or if there's nice 3, then we would not recommend stepping down. Finally, in respect of communication standards, I think it's possibly the most important slide. Where we see a cancer, we must inform the patient on the day, use clear language in the report and in our communications with patients. If we see a cancer, we've got to use the word cancer when we are describing that. Step down where appropriate, and record that step down clearly in the report also, and explain that to the patient too. Refer to the relevant MDT in real time. Don't leave anything to chance. Make sure that that happens at the time of endoscopy, and request staging where appropriate, and consider same-day CT, chest, abdomen, and pelvis where that's available. And these standards have to be consistent. There shouldn't be an exception for weekends or outsourced lists, and so I would encourage clinical directors and endoscopy leads to ensure that these communication standards are built in to any contracts or negotiations with outsourced providers when they're being used or contracts are being tendered. So we have consistent standards for all patients in Greater Manchester who are going through lower GI cancer pathways. Thank you for your time and attention.
Hiya, my name's Meg. I'm the Upper GI Cancer Pathway Navigator here at Salford Royal Hospital, and I'm here today to speak to you a little bit about my role as a navigator within the optimal straight-to-test faster diagnostic standard endoscopy step-down process, which aims to provide optimal service delivery, effective endoscopy capacity, and an overall really good patient experience. So the first thing that will happen in this process is the patient will get referred into our electronic referral system. That's then picked up by the triage CNS, who will call the patient and take a full history. That's then passed to me, and I will aim to call and book the patient in for an appointment within 24 hours. During this phone call, I'll make sure that the patient is aware that they've been referred on a faster diagnostic standard pathway, the reason why they've been triaged for a gastroscopy, and answer any questions that they might have at that point. I will confirm the appointment, provide instructions of any preparation. So for example, if the patient's having a gastroscopy, I'll tell them that they'll need to be nil by mouth for 6 hours before the appointment, and whether or not they need to attend with a chaperone if they're going to have sedation. I'll then follow that up with a letter and a text with all the instructions on. The patient will then attend the endoscopy unit for their investigation and be stepped down at endoscopy. The patient will know they've been stepped down at endoscopy because that would have been communicated to them, and they would have also left the department with an endoscopy report anyway, which will say step down from endoscopy, and a few little questions at the bottom which kind of say, can the patient be stepped down, yes or no? So the patient will know on the day whether or not any further tests need to be taken, but most importantly the patient will know that there's no suspicion of cancer. I will then follow that up the next day and pop that onto any electronic systems. The clinician will then dictate a letter to the patient and the referring clinician, and the AMDT coordinator will remove that from tracking. So this whole process provides a really, really good patient experience, and provides the patient with an understanding of the entire process throughout, and completely reduces their anxiety. They don't need to wait for a result. They don't need to wait to be stepped down after their scope because it's on the day, and it really supports cancer performance by removing patients from tracking once no cancer is confirmed. Step down is documented there and then and gives transparent paper trail for a patient pathway.